Hi, everyone. I'm going to keep this short and sweet since we're at the end of the day. Um, so basically, I'm going to talk about this SMS campaign that the End Fund participated in Zimbabwe. And normally, this is not really something that we would do, but there was a perfect storm of opportunities that came our way. And so we thought this would be a great way to just dip our feet into something that I think could be a really big, impactful tool for global health. So just quickly about the End Fund, I know a lot of you out there know who we are, but for those who don't, we're basically a philanthropic initiative that finances NTD control programs, and mainly through the private sector engagement. So our mission is to end 5 of the most common neglected tropical diseases. And we kind of have different approaches, but really for this talk, it's really about engaging the private sector, and not just through funding, but through in-kind donations, because we happen to partner with a telecommunications company that really was instrumental in our SMS campaign. And these are the 5 diseases that we work on: intestinal worms, LF, river blindness, schisto, and trachoma. So just to give you an overview of the ZIM program, in 2012, the MOHCC, which is the Ministry of Health and Child Care, launched the very first MDA campaign, which was working towards a national plan. So it kind of revitalized the primary health care system there, because they were just trying to rebuild after a devastating economic crisis. Now, once we joined with them, we worked with Higher Life Foundation, which is also affiliated with Econet Wireless, which is Zimbabwe's largest telecommunications provider. And basically, the program in Zim was looking at doing a 3-year initiative to reach national scale for intestinal worms and schistosomiasis, and then later on, as of 2016, lymphatic filariasis and trachoma. So one of the biggest challenges that we were facing as recent as 2016 was that certain treatment areas were getting pretty low coverage, and it was mainly because of a lot of mistrust in the community. There is already social mobilization in place in ways of posters and pamphlets and radio spots, but a series of events were contributing to community skepticism, especially of the ministry. Some of these were media reporting on previous adverse reactions at the same time as MDA was happening. So it wasn't necessarily related, but there were some illnesses or deaths around the time we were doing a school-based deworming program. And so the media made that link, and all of a sudden everyone in the community was afraid to participate in MDA. There was also a bit of a lack of crisis communications planning on behalf of the MOHCC. And because of that, when certain things like fake news, which is kind of relevant to today's world, came out, they couldn't really get in front of it. So for example, just I believe it was in the July MDA campaign for schisto and STH, there was it was mainly an online media outlet, which I would equate to maybe the National Enquirer in the US, and they went out and said that there was a wrong shipment of pills that arrived in Zimbabwe, and they weren't really for NTDs, they were to sterilize people. So all of a sudden, people didn't want to take those pills. So just to pan out a little bit and talk about new technology in global health. In 2013, the WHO began to include new tech to support healthcare delivery as one of its priorities, especially in resource-limited settings. This included cell phones and mobile phone usage. So some of the benefits of that, I think, are pretty obvious. It's cost-effective and familiar. Everyone has a cell phone. I'm sure everyone in this room has a cell phone. And we know, just walking around outside in different places, everyone's on their phone all the time. And it's also a very simple distribution method, and it has a broad reach. When you try to compare that to, for instance, posters for social mobilization, it takes a lot to take a poster and take it into a very remote area or travel throughout a country that's, quite large, whereas through cell phones, all you have to do is send one mass message and it gets around to different areas. And it also allows for customized, non-invasive, and easily adaptable messaging. So you can target it based on the region or the province and depending on the different cultural nuances in certain areas. And so just some ways that it's been already used in global health includes improving communications between healthcare provider and patients. For instance, there's a lot of SMS usage for reminding patients when to take antiretroviral medicine or anti-malarial medicine. It's also used for improving coordination among health workers. So this is really great for operational efficiency when delivering healthcare. And then social mobilization and community engagement, which is basically what we were using it for. And it's just getting the community buy-in. I also put social media here because it was a small part of the program that we did, but just intuitively, when you think about it, with mobile phones comes social media eventually. So, the growing popularity of social networking apps, is on the rise, and it's the more accessible internet is going to be, the more I think social media will play a part in in community engagement and social mobilization. So just to take a quick look at the Zimbabwean communication landscape. So as you can see, there's the urban statistics and the rural statistics, and this is from 2014. So in both cases, you'd see that the mobile usage is much higher, and this is where people get most of their information. And especially in Zimbabwe, there's been a sort of mobile revolution, if you will, in the rural areas where a lot of people, even if they don't have running water or heat or anything like that, they have cell phones. So 84% of the population has at least one person in their household who has a cell phone, compared to a radio or TV. In the urban area, it's still higher, but it's not that different when you really think about it. And one of the reasons why is because in Zimbabwe's rural areas, there's not a lot of options for different sources for getting information. If you're in the urban area, you have internet cafes, you have, other ways of communications, but in rural areas, the mobile phone is basically a multi-purpose tool. That's how people get their news. That's how people use, essentially, sometimes it's their radio, it's their banking system. So we kind of looked at this and we're like, okay, there's something here. So for the Zimbabwe SMS plan that we put in, first of all, it was very opportunistic. We didn't have a real plan to begin with. Like I said, this is not our specialty. We hadn't really done this before. And so we had a board member who was also a donor and is also the owner of Econet Wireless. And so she was like, oh, well, it'd be interesting to see what Econet could do for NTDs. In literally a month's time, maybe 3 weeks, we kind of put a plan together and tried to just put it out there and see what would happen. So our main goal was to spread awareness about schistosomiasis, intestinal worms, LF, and disseminate information. And the target was basically looking at all the subscribers in those at-risk areas and sending just a mass message. But obviously, they would be targeted for each disease. And the main audience that we were trying to target were the decision makers in the communities. So that would be the community leaders, the religious leaders, influential community members, and heads of households. And then also just to talk about the distribution plan, we didn't have a lot of time to lead up to the campaign. So for Schisto, we basically sent out one targeted message to the areas. And then for LF, because it was going to be a newer disease that hadn't previously been treated for, we did two. We did one message that was kind of a general national message, and then the second one 2 days before the campaign started to remind people where to go and how to seek treatment. So our reach. we were able, in the first round, which was for schisto and intestinal worms, we're able to reach about 600,000 subscribers in that targeted area. And that was a sample of the message that was sent out. And then for the round 2, which happened about a month or two later, we were able to reach 3.7 million subscribers in that area. And that's an actual picture that came out of a text message that came out while we were there on a visit. And for round 1, the success rate was about 85%, and success rate meaning of people actually receiving the message. And then for round 2, it was 70%. And there was also a social media component to this, but it wasn't as built out just because we didn't have enough time. So it was really a matter of just getting all the partners together and being able to use our unique networks to just blast Twitter messages, Facebook messages, and WhatsApp, which is also very big in Zimbabwe. So for the main part of this talk, which is what were the lessons learned? Well, we saw that there was a lot of, even though we don't have results back necessarily, we saw that we were building awareness because we had a lot of anecdotal information that came back to us about someone's friend who got the message and showed it to us. Even our own CEO, who happened to be in Zimbabwe at the time and had a SIM card, got it to her phone. So it was kind of nice to see that no matter what area you were in, the messages were getting out there. The other success was for the MOHCC, who previous to this didn't really have a focused strategy for media and communications. And because of all that they were going through with negative media and low coverage rates, I think they saw the opportunities and the effectiveness of tech and media tools. And so they really were interested in building this out further. And the biggest success, I believe, was the opportunities for partnerships. Through this kind of random and bit of, crazy partnership, we were able to see who was actually in our network and how much they can contribute to NTDs. I mean, I think all of us being here today kind of shows that you can find partnerships in unlikely places, and they could be really beneficial. And so using the private sector resources and not just through funding was really amazing. I mean, this, I think, cost Econet Wireless about $4 million, but it was done as a donation for us. And then it also tapped into the millennial demographic, because as a result of this, this project, we were able to connect with the global shapers, who are the World Economic Forum's initiative of engaging young, influential people in these different endemic countries. And so through them, they were able to create a social media campaign soon after this text messaging went out, and now want to build on it and make it a component of the next, the next phase. So the challenges that we saw were, some were very obvious and some were kind of over our heads because we didn't anticipate all this, some of the technology behind it. For instance, the fact that an SMS can only be limited to 160 characters. This is very interesting for a country that doesn't only speak English, because for instance, two of the main languages there are Shona and Ndebele, which I don't know if anyone here speaks any of those, but just to write one word, sometimes it's very long letters, many letters. So it's impossible to create a whole message just in 160 characters in Shona or Ndebele. So we were restricted to just using English. The other issue was the distribution limits, and that was in two ways. One is that the way that the SMS was sent out was not based on if you lived in this certain area. It was really on how many phones or which phones were turned on in a particular area that was being targeted. So it was literally taking a snapshot of what phones were signaling off the tower at that given moment. That could have a positive effect and could also have a negative effect, because you could be from Mashonaland West and be in Bulawayo, and the message is going out in Bulawayo, and you happen to get it, And so it's kind of spreading that message that you would not normally get. But inversely, you could be from Bulawayo and not be there at the moment and not get that message. Secondly, the success rate of receiving those messages is based on whether your phone was turned on, if you have a certain type of phone. So there could be a whole group of, a whole population that could be missing out because of that. And then lastly, the social media reach is not always clear, and you know, we can base it off of engagement or anything like that, but it's very hard to put limits on how effective social media is. So lastly, the road ahead. Obviously, one of the biggest things is that we need a better tracking and monitoring and evaluation system. And that's what we plan on doing. And some of the ideas that we have are doing surveys at MDA sites to see who actually is there because of a message that they received. Because there are too many factors to be able to make a conclusion to say, okay, well, so-and-so got the message on their phone, we know they opened it, and because of that, they're gonna go and get, participate in MDA. And the other option is to have a built-in reply to or check-in through the phone. So someone could reply back saying, yes, I received an MDA, I received a pill because of this message, or someone could check in at an MDA site to show that, okay, this is being recorded, they received the message, they actually went. And then just building out the plan better. And I think one of the reasons why we wanted to be here and talk about this, even though it wasn't a full-baked plan, is because we know SMS and social media have been used a lot in global health. And so if there are people out there who have advice or who want to learn from some of our experiences, then this would be the opportunity to just connect on that. That's it. Mm-hmm.